My presentation's on throwing mechanism. Has 6 phases. The first phase is wind up. The second phase is stride. Third phase is arm cocking. Fourth phase is arm acceleration. Fifth phase is arm deceleration. And the sixth phase is follow through. The anatomy, the bony structures are the humerus, the scapula, and the clavicle. Some important anatomical structures of the humerus are the anatomical neck, the humeral head, the lesser and greater tuberosities, and the intertubercle groove. The glenoid labrum articulates with the head of the humerus. It's a shallow fibrocartilaginous structure spanning from the scapula. It adds extra stabilization, but it doesn't compromise range of motion as much as a bony structure would. Scapula is very important for bony and muscular articulation. It aids in accessory movements of the shoulder, and it is the origin for all of the sits muscles of the rotator cuff. The clavicle is a elongated S structure that articulates with the sternum and the scapula. The rotator cuff is important for movement of the shoulder and throwing mechanism. The supraspinatus originates in the medial 3/4 of the supraspinous fossa and upper surface of the spine. Its action is abduction of the shoulder, and it also stabilizes the humerus. Its insertion is the superior facet of the greater tubercle of the humerus and the joint capsule of the shoulder. Its innervation is suprascapular nerve C5 and 6. Infraspinatus originates from the medial 3/4 of the infraspinous fossa of the scapula and fibrous intermuscular septa. Its action is to internally rotate the shoulder and stabilize the humerus as well. Its insertion is the middle facet of the greater tuberosity of the humerus and the capsule of the shoulder joint. Its innervation is suprascapular nerve C5 and 6. The teres minor originates in the middle 1/3 of the axillary border of the scapula. Its action is to internally rotate the shoulder and stabilize the humerus. The insertion is on the inferior facet of the greater tuberosity of the humerus and the capsule of the shoulder joint. The innervation is the axillary nerve C5 and 6. The subscapularis originates on the medial 2/3 of the subscapular fossa. Its action is to externally rotate the shoulder, and it also stabilizes the humerus. The insertion is the lesser tuberosity of the humerus, the medial lip, upper medial lip of the bicipital groove, and the capsule of the shoulder joint. Its innervation is upper and lower subscapular nerves C5 and 6. Some more muscles that aid in throwing mechanism movement are the trapezius, deltoid, pectoralis major, biceps brachii, subscapularis, pectoralis minor, coracobrachialis, serratus anterior, trapezius, deltoid, rhomboids, and levator scapula. The trapezius is a large posterior muscle that originates in the medial 1/3 superior nuchal line. Ligament nuclei, spinous processes and supraspinous ligaments to T12. Its action is to laterally rotate, elevate, and retract the scapula. With the scapula fixed, it extends and laterally flexes the neck. The insertion is the upper fibers to 1/3 of the posterior clavicle, acromion, and the superior spine of the scapula to deltoid tubercle. The nerve is the spinal accessory nerve C1 through 5. The deltoid originates on the deltoid tuberosity. The action is to abduct the shoulder. Anterior fibers flex and medially rotate the shoulder. Posterior fibers extend and laterally rotate the shoulder. The origin is the deltoid tuberosity. The insertion is the lateral third of the clavicle, acromion, spine of the scapula to the deltoid tubercle. The nerve is the axillary nerve C5 and 6. The pectoralis major originates on the medial half of the clavicle, manubrium of the sternum, the 6 upper costal cartilages, and the external oblique upper neurosis. The action is to flex the shoulder and adduct the shoulder, medially rotate the shoulder, and it is also an accessory for inspiration. The insertion is the lateral lip of the bicipital groove of the humerus and anterior lip of the deltoid tuberosity. The nerve is the medial pectoral nerve and the lateral pectoral nerve, C6, 7, and 8. The biceps brachii has 2 heads. The long head originates on the supraglenoid tubercle of the scapula. The short head originates in the coracoid process of the scapula, along with the coracobrachialis. The action is supination, elbow flexion, and weak shoulder flexion. It inserts on the posterior border of the bicipital tuberosity, the radius, and the bicipital aponeurosis to deep fascia and subcutaneous ulna. The nerve is the musculocutaneous nerve C5 and 6. The pectoralis minor originates on ribs 3, 4, and 5. The action is rib elevation if the scapula is fixed, protraction, depression, and stabilization of the scapula if it's not. The insertion is the medial and upper surface of the coracoid process of the scapula, and the nerve is the medial pectoral nerve C8 and T1. The coracobrachialis originates on the coracoid process of the scapula. It has elbow flexion and weak adduction. Its insertion is the upper half medial border of the humerus and the musculocutaneous nerve C5, 6, and 7. The rhomboid major originates on the spines of T2 through 5 of the supraspinous ligaments. Its action is retraction of the scapula. The insertion is the lower half of the vertebral border of the scapula, and nerve is dorsal scapular nerve C5. The rhomboid minor originates in the lower ligamentum nuchae of spines of C7 through T1. The action is to retract the scapula as well, and it inserts on a small area of the vertebral border of the scapula. The nerve is the dorsal scapular nerve C5. The scapula inserts on the upper vertebral border of the scapula. The action is elevation of the scapula. It originates on the posterior tubercles of the transverse processes C1 through 4. The nerve is the anterior primary rami of C3 and 4, and the dorsal scapular nerve C5. Some important shoulder ligaments for throwing mechanism include the interclavicular, anterior sternoclavicular, costoclavicular, coracoacromial, coracohumeral, glenohumeral, coracoclavicular, conoid, trapezoid, and acromioclavicular ligaments. You can see where the 3 ligaments lie. The interclavicular ligament connects the 2 clavicles together. The anterior sternoclavicular ligament connects the sternum to the clavicle, and the costoclavicular ligament connects the ribs, costal cartilage, to the clavicle. Here are 3 more important ligaments. The coracoacromial connects the coracoid process and the acromion. The coracohumeral ligament connects the coracoid process and the humeral head, and the glenohumeral ligament connects the scapula to the humerus. Three more important shoulder ligaments are the acromioclavicular and the conoid and trapezoid ligaments. The conoid and trapezoid are the two coracoclavicular ligaments. The first phase of throwing mechanism is the wind-up. It has a very low chance of injury with little muscular movement, and the shoulder is typically stabilized. Wind-up muscles include the teres minor, infraspinatus, supraspinatus, trapezius, deltoid, serratus anterior, and subscapularis. The purpose of the wind-up is to balance and stabilize the body in preparation for the other phases of throwing. The wind-up movement includes upward rotation and elevation of the scapula, abduction of the shoulder, movement from the static position to the balance point where the knee is lifted completely. Phase 2 of throwing mechanism is the stride phase. Stride injuries include glenohumeral instability, which is weak stabilizing muscles, laxity of the ligaments, or damaged glenoid labrum. Stride muscles include the supraspinatus, infraspinatus, deltoid, serratus anterior, and the upper trapezius. The supraspinatus performs abduction of the shoulder, the infraspinatus performs external rotation, the deltoid abducts the shoulder, the serratus anterior upwardly rotates the scapula, and the upper trapezius elevates, upward rotates, and adducts the scapula. This movement is from the balance point to when the lead leg contacts the ground. The arm cocking phase is the third phase of the throwing mechanism. Arm cocking injuries include anterior instability and anterior impingement syndrome. This occurs when there is not enough space between the acromion and the humeral head, and the supraspinous tendon becomes inflamed. Arm cocking muscles include pectoralis major, supraspinatus, deltoid, latissimus dorsi, triceps brachii, teres minor, trapezius, the rhomboids, pectoralis minor, subscapularis, and serratus anterior. The arm cocking concentric motion is performed by the deltoid with shoulder abduction, the supraspinatus with shoulder abduction, triceps brachii with elbow extension, trapezius with scapular adduction, the rhomboids with scapular adduction, infraspinatus with shoulder external rotation, and teres minor as well with shoulder external rotation. The arm cocking eccentric movement includes the pectoralis major, shoulder internal rotation, pectoralis minor, scapular abduction, latissimus dorsi with a shoulder internal rotation, serratus anterior with scapular abduction, triceps brachii with elbow extension, and subscapularis with shoulder internal rotation. The fourth phase is the arm acceleration phase. Arm acceleration muscles, concentrically, the latissimus dorsi internally rotates the shoulder, the pectoralis major also internally rotates the shoulder, and the triceps brachii extends the elbow. The arm acceleration movement begins at maximum rotation of the shoulder and ends at the ball's release. This is when maximum force of the external rotation occurs, and this predisposes this phase particularly towards injuries. The fifth phase is the arm deceleration phase. Arm deceleration injuries include superior, labrum, anterior, and posterior tear, which is a slap tear, and also a teres minor strain. This can occur from the slowing of the eccentric contraction of the teres minor. The arm deceleration muscles include eccentrically contracting the teres minor, which is for shoulder external rotation, infraspinatus, which is also for shoulder external rotation, the deltoid for shoulder abduction, and the latissimus dorsi for shoulder retraction. The arm deceleration movement begins with the release of the ball and ends with the slowing of the arm through eccentric contraction of the muscles. Deceleration occurs through internal rotation and horizontal adduction. This is the highest torque of all the throwing phases. The follow-through is the last phase, it's phase 6. The follow-through injuries include biceps brachii strain. This can be caused in the muscle tendon or the muscle belly. The follow-through muscles concentrically contract to bring the throwing arm to its final position. The biceps brachii flexes the elbow. The pectoralis major horizontally adducts and internally rotates the shoulder, and the deltoid horizontally adducts the shoulder. All muscles are also required to bring the body to the resting state of its original position, and all muscles also stabilize the humeral head and the glenohumeral joint. The follow-through movement begins after the arm is decelerated and ends with the final resting position and balance from the throwing motion. This is the highest force on the biceps brachii to decelerate the elbow, which is typically why it's injured through this movement. Here are the resources.